So welcome to week 3. You've made it to week 3. You're a quarter of the way through, and it's going to go by very, very quickly. And I'm going to warn you with that. You guys have been really good about keeping up with your homeworks, your discussion questions. I have not completed the discussion questions yet, but by tomorrow you'll have, your grades on them. Week 3 is you have NCLEX questions due, and you have a quiz at the end of class. It's on last week's information, school age and adolescence. And you have getting ready for your unit exam 1. I've already done a review. I've already posted it on your announcements. And as soon as Professor Brunel does hers tomorrow, I'll be posting it on the same announcement. So probably by tomorrow, afternoon, you will have that other review. We like to do one during the week, one on the weekends, because some people don't work on weekends or work during the week. It just seems to work out the best. So I like giving you that opportunity. The reason why I chose Tuesday at 2, it was actually the second class I do tonight, the 6 o'clock class, Eastern time. They said it would be a great time for them, and I had a pretty decent turnout, so I was very happy with that. Next exam, I'm going to ask you what you want for the time and the date that I do the review, and let's see if I'm not teaching or have other responsibilities, okay? So I will do that for you. So today, what are we going to do? We're going to do chapter 22, healthcare adaptations for the child and family. I have a PowerPoint that we'll be going over. Always remember with those PowerPoints, there are notes on many of the slides that make you think. And I do like them. I've added some to that. So always look at them. If you like to print them, if you print them with the notes, it actually will bring you up with all of that, but it's 1 page per slide. So it's going to be 48 pages. So that's the only thing, doing it that way, instead of putting it 3 or 5, whatever slides per page. So it's up to you, but you can always review it online to do it that way digitally. When we're done, we do have a Kahoots. We'll be doing that. And hopefully we'll be done somewhere about 5 o'clock. We'll do our quiz. And because we're not going to take any big break, we are going to get out early. And is that okay with all of you? All right. I know you guys are busy. I know some of you have already had another class today. I was just talking to a student earlier and my head was getting dizzy listening to what all had to be done. So let's go ahead and start with our PowerPoint now. Remember, anytime during this, you're not understanding, you have a question, please stop me. I do not mind. I don't get upset, and I welcome questions. Remember that, okay? So, admission to the pediatric unit nursing. What are the nursing responsibilities? Well, we know consent is a big deal. Remember, consent is part of HIPAA. Like, who do you talk to? Who gives consent, right? Now, we know parents can give consent for any child that is cognitively delayed, even if they're over 18. Also, any child 17 or less, if they are not cognitive delayed. Now, an 18-year-old can sign and will sign their own papers for admission to a hospital, to an ER, urgent care, doctor's office. And remember, the 18-year-old is the one who has to give consent to the parents to get information, okay? It's a change that you have to remember and think about. Also, though, if you have a younger child, 16, who has a child herself, that mother, she's a mother, she can give consent. So there's a lot of different ways that there's differences in giving consent for treatment. If you don't know, make sure you ask someone. There also is consent that is given where in an emergency place where, let's say a patient, it doesn't matter young or old at this point, but even the younger ones, because we're pediatrics, right? If a child comes in by rescue or on a helicopter and there's no parents, we can give emergency treatment to save the child's life. without anybody's consent. It is said by state law, 2 physician signatures suffice as that consent. And as soon as the parents come, we know that if they're in the ER, that ER admission staff is running around getting that parent to sign it as soon as they possibly can. It's part of their job that they do. But we as nurses must know who and can and when do we give information out, right? So if you have an 18-year-old patient and mom comes to the desk and this patient's awake and alert and oriented and wants to know a lab result, you're gonna have to ask your son. I can't give you that information. He's a consenting adult, okay? Now, as we're giving information out, we can give information to our patients. Just because, they're younger doesn't mean they don't have the ability to understand. Again, always get on their age level so they can understand. I think a well-informed child will take care of themselves, because a parent can't be looking at a child 24 hours a day, can they? And that child, if the kid has a broken arm and we don't tell them about not getting it wet, how to take a shower, how to exercise the hands, keep it elevated when they go home, are they going to do it? Because the parents don't always relay that information, and we know outcomes will be better. Now, one thing that's a huge thing today is ID bracelets. I know many hospital units. I know the ER that I just came from. They would go around at least once a week and make sure that everybody had an ID bracelet on. Why do you think we have ID bracelets on? To prevent errors, because remember, for instance, in ER, even doctors' offices, even on the units that we will work, these patients come in and out so quickly, we can't remember who is what name, and we don't want to make any mistakes. So we always check the ID bracelet. And you'll say, what is your name? You check the ID bracelet. What's your date of birth? Check the bracelet. So now we know that any treatment, any medication, any procedure will be done on the correct child or adult when you get there. Now, safety is huge. By the time an infant is 6, 7 months old, they can roll. So these children can roll off cribs, roll off, weighing scales. And I've seen premature infants that were barely 3 pounds roll off scales on nurses, that the nurse didn't have that child properly secured and fell off onto the floor. And it devastated that nurse's career. She, in her mind, couldn't work anymore as a nurse because, she was afraid she could have done really bad harm to that child. Now, the kid had a bruise that was not a big injury, but it could have been, right? Falling on their head, almost. Yeah. So keep the side rails up all the time. Even if the mother's there, remind them they turn their back to, put the rails up. Or sometimes they have doors on the side of the cribs. Make sure it's closed, because those children will get out and they will hurt themselves. We used to say, oh, I'm going to go to room 203A and give medicines. And that we know by looking at history and medication errors, it causes errors. So again, always go by the ID bracelet, not by room numbers. Now, some of these kids are Houdinis, especially when you get to those toddlers, right? I call them my dive bomb kids, because they climb up and jump, and they want something, they're going to find a way out and to get it. So they have these tops now on top of the cribs so that they can't climb up and out. But again, make sure those side rails up and they are secure, or you'll be filling out an incident report. Now, when we're taking these cribs, many of them are on wheels, and sometimes parents move them around because a lot of parents want to stay with their children. Make sure they're not next to things that they can hurt themselves, because we have electrical sockets that are higher, we have oxygen that's higher, we have all sorts of things that are higher up on the walls, and those cribs put these children up at that level. So make sure they can't touch anything and hurt themselves. When you are doing your assessment, I always check the crib, what toys are in there. Is there anything sharp, anything that can cause, injury? Or if they're too small of pieces, I wouldn't leave them in a crib. These need really good supervision, if not at all, okay? At home, these children need to be taught about their medications and all of these cleaning stuff that are underneath the sink, underneath the bathroom sink, or out in the open. Children get into it. Now, the most of the medicines that I've seen that were overdosed on was vitamins. And actually, vitamins are benign, believe it or not, because what your body doesn't need, it will just excrete in the urine, unless it has iron. And you could become iron toxic. That could be a problem. Or how about Tylenol? What is Tylenol? Acetaminophen. If we take too much of that, it can cause liver damage. I've seen that. I've seen kids eat rat poison. I've seen kids eat Tide balls, in their mouth. Those things are dangerous. So again, keep all of these things out of the reach of children so they can't get to it. I know many times we go over to Nana's house, like my grandson come to my house. I always had to make sure that there was no medications out and they were up in places where he couldn't touch it. So thank God, knock on wood, my grandson never got into anything from my husband or from me. Now, this is going to be the hard thing, preventing cross infection. So in daycare, you're not going to have the ability to make sure that something's clean before it goes from one kid to another kid. But at home, if you are using your nephew or your sister's kid stuff, make sure you clean it before you bring it in the house, because we know viruses and bacteria can last a long time. So make sure we clean it with a good antiseptic before we bring it in. I know many times we'll borrow high chairs or cribs and all of those things. So just make sure that we do clean it well. Now, many kids, due to respiratory illness, prematurity, need oxygen. A lot of the premature children, they're born and their lungs are not mature. And we give all of these surfactants and stuff to help the lungs work well, but still they're damaged. Plus, as a premature infant, you're going to see them getting a lot of infections because there's no immune system. And a lot of it is in the respiratory, so it damages the lungs. So a lot of times they're sent home with oxygen. Remember, we need to teach our parents, all of those things about oxygen, no flammable liquids, no fire, matches, smoking next to it should not be done, okay? Because it can cause a fire, because oxygen is flammable. Now, another safety thing is, children love to go out, especially, the toddlers and the preschoolers, go out, find a wheelchair and play with it. Sometimes Children's Hospital have wagons that will sometimes bring them, to x-ray or procedure in. They should not be playing with these things by themselves, because they're not toys. And remember, can you imagine how many germs are on this? And remember, especially the younger children, again, no immune system. So we don't want that. Never leave a kid who is in a high chair or at in a swing or just sitting up at the table. Should never be left alone, because they can fall off, hurt themselves. They can get on top of the table and they can hurt. So always be observing these children. Little kids, even, the infants can be crawling all over the place. So make sure that they're not left alone, outside of the crib. They can get into stuff so quickly, and at 1 year old, again, at that age of going into toddler, they get into everything. So you don't want them to hurt themselves. You don't want them to swallow things, stick things up their nose and their ear, because I've seen, little crayons in their ears. I've seen food in their noses, that they can't get out, and they come to the hospital, and we have to, because they can't blow their nose. They don't really know yet, some of the younger ones. So we've got to get these things out, like little alligator clamps to get things out of the ears, little pieces of crayons. I've seen quite a bit, in the ears. And then, of course, the food, and of course, little crayons in the ears too, and the nose too. Medication should never be left at bedside. The kid can't take it right then. You take it with you back to the medication room and bring it out when they're ready to take it. And they do not never have, said that propping bottles is good. Because what happens is if you prop a bottle and, if you had multiple births, like you had twins or triplets, it's very difficult not wanting to take and prop a bottle because you've got three of them crying or two of them crying, right? But remember, when they're drinking, sometimes it still leaks and they can choke on it and aspirate it. And aspiration pneumonia is an infection and can cause severe respiratory distress. And if a kid doesn't want to eat, if you try to force feed him, again, he's going to choke it again. So we wouldn't want to force feed. Now, how do we transport, position, and restrain? And, we do restrain sometimes, and sometimes we do need position for some sort of procedures. And we know if you're going for an x-ray, you got to get somewhere, right? Well, it all depends on the age of the child and their level of consciousness and, of course, medical care. If they're intubated, the endotracheal tube, they're going to go in their bed or their crib, whatever they're in already. But if the child is awake and alert, a lot of times we will make it fun. We'll put them take them in their crib and they sit up and watch. I mean, infants go in their cribs all the time. Older kids, we could put in wagons, and a lot of them do have those seatbelt straps so they don't crawl out because that's what the kids want to do. Whereas we even have large wheelchair for large size people, we have pediatric size for those smaller children so they can sit there. Many a times we'll put the parent in the wheelchair, we'll get a regular size one, and we'll put the child in the parent's lap. That works too. Or we just put them on a stretcher if we're going to the OR, let's say. If we are transporting them, they're in a crib or even in their beds, we need to keep the side rails up. We still need to have that safety because they can roll out of bed. Always before we transport, check that ID bracelet, make sure it's the proper patient. And of course, we always check two forms with the ID. We'll do the name and date of birth. Those are two good telltale signs we got the right patient. When we are transporting, always document when did they leave and who did they leave with and where were they going, so that there's a documentation they left the unit and where did they go. Positioning children, is done. Let's say we need to start an IV or we need to do a urine cath. Position them in the right way and trying to make it as comfortable as possible and teaching that child, the older ones, why you're doing that. Restraining them would be, holding them to get that IV, holding that arm. We don't use restraints routinely, like wrist restraints or ankle restraints. No, we try to do everything possible not to restrain that child and hold them down, okay? Even in the adult world, we don't like restraining them. Yeah, we have chemical restraints where they have an endotracheal tube in and they're on medication to paralyze them because of their condition, but that is the only restraint that's really used today in hospitals. Always remember when you're doing an assessment that they're not little adults, they are children. When we do an assessment on an adult, we do head to toe, right? Easy. We figure it out. Children, no. If you have an infant asleep in a parent's arm, you know what you're going to do? You're going to listen to the heart sounds and the breath sounds. The kid's quiet, kid's sleeping, you're going to hear it. And then you're going to do it according to the child's needs. If they are tolerating an assessment and you can make fun and play with it, you're going to be, then feeling for pulses and looking at neurostatus and listening to the bellies, etc. But remember, when we're doing this assessment, we're looking for, so we gave them ibuprofen, had a fever. We're going to go back and assess them, look how they're feeling, Their color, are they still flushed? Listen to the heart rate. Is it still elevated? And the respiratory rate could still be elevated, right? But you give this Tylenol or you give the or acetaminophen or ibuprofen, fever comes down. How do we know it worked? Well, they're not flushed. They are more active because kids with fever sit in a corner, don't want to eat or drink. Well, now they're drinking fluids, they're eating, they're running, their heart rate is decreased, their respiratory is decreased, and their color is not flushed like with a fever. So whenever you do a treatment, make sure you go back and look, did it work or do I need to do something else? So an infant assessment. Well, we know young infants cannot hold their body temperature, especially the young ones. They don't have adipose tissues and they've got big heads, which loses heat like crazy. So be in a nice, quiet, non-stimulating room and make sure that it's warm. As you're doing the assessment, don't just strip the baby naked and do an assessment. Do it little by little, keeping that child covered as much as possible. And as I said, first you're going to look at that child. You can see respiratory rate, you can see their comfort levels, you can see if they're in pain, crying, you know, by just looking. So observation is key in infants. There's two things, well appearing and sick appearing. And children, you'll know the difference just by looking. Then you do as minimal touching as possible. And the last thing you do is going to be those reflexes, making sure their knees go up and down, and blood pressure, because kids don't like blood pressure. Those are the more invasive and they can hurt. So you don't want to do that first because then you're not going to get anything else done on that child. Again, you're going to talk quiet and softly and, talk, to the infant, say what you're going to do, but very quietly. Let me tell you, infants understand the quiet voice. They may not understand what you're saying, but you're actually talking to the parent as you're talking to the infant. So you're teaching a parent, teaching the child, but your soft voice is all they want to hear. We know a pacifier soothes a child. It's a self-soother, right? Any stress, they can release stress by sucking on a pacifier. So absolutely have them with a pacifier to comfort them. When they're done with the assessment, take them, wrap them back up and give them back to the mother. I do a lot of assessment in the mother's arms. Where is an infant most happy? In mommy's arms, right? So I can listen to so many things and find pulses and everything. So when you're done, if you had to lay them down for some reason, make sure you wrap them up nice and tight. They like that, hands to the midline there. And, the mother always wants to give them a hug. And as I said, this is that parent teaching opportunity. You're talking to the child, but you're really talking to the parent. Then when you're done looking, examining at your child, then you're going to document the findings on your nursing record. So what are some of the things you're going to look at? Well, number one, well appearing, sick appearing. Those are the two things. Then you're going to look at the child. Are they small? Are they big? Are they heavy? Are they skinny? Are they developmentally where they need to be? Very important. Many times it's a nurse who tells a physician, this child is behind. I saw this, this, and this. Could you go check that out? And they will, and they'll probably give some early intervention for that child. There's speech therapy, physical therapy, occupational therapy, and those things can catch children up really quickly. But many times it's the nurse. We spend more time with these kids than do doctors, don't we? We know that. Another thing when you see a child is, how are they responding to the parents? How are they responding, in the environment that they're in? Is it normal, or is this kid look withdrawn and depressed? Is there good interaction between parent and child? You can tell things like that. I know older kids, working in the ER the last 10 years that I worked, I would see kids that'd be sitting there quiet, withdrawn, and not moving or saying anything. And the parents just sitting there and ignoring the child. Or I've seen the child sitting on the parents and them sitting there talking and, the parent comforting them. I've walked into rooms where they've taken the sheet off the stretcher. They found all the earpieces for the otoscope, thrown everywhere. They've gone into drawers, pulled out alcohol swabs, gauzes, so what is that reaction? The parent, the child, and the environment. Now, a lot of things that we can see, again, is by observation. If a child is dipping the head, especially younger kids, they can't talk yet, and they're dipping their head and rubbing ears, you're going to say, what could that be? Well, it could be an ear infection. Sometimes that's the location they're telling you. Maybe they have a grimaced face. Maybe they are crying, but if they're going like that or they're touching their ear, you can say, I bet that's where it's coming from, okay? Another way to look at pain is the child moving a lot, or are they just rigid, not moving? If they're rigid, not moving, something's going on. Children, especially young kids, don't sit in one place long. So if they're in a hospital or they're ER, or the doctor's office, and they're just sitting there and nothing's going on, and you could see the facial expressions, is something to look at, okay? Another thing is, are they sitting there leaning over, just trying to breathe? Okay, you'll see the shoulders up. You're going to see retractions, supraclavicular. Now, right between the clavicles, there's this little space. And in the children's world, it's going to pull in when there's respiratory distress, whether it's asthma, whether it's some pneumonias, sometimes groups, all of those respiratory things can cause it to go in and out. So you're going to see how they're breathing, right? You can hear it too. And then we're going to look, are there any bruising on this child? And we're looking for, is a kid prone to injuries, or is it maybe an abuse case? I've seen a 3-month-old that had a skull that was cracked and had a huge bruise behind the ear. And immediately I was like, oh, this is not normal, a 3-month-old. And there was no information from the parent regarding that. So I went in and told the head physician. So he said, go ahead and do an x-ray. And we did an x-ray of the scalp, and we found a fractured skull. And we went in and did an x-ray of the body, because they fit on a whole x-ray plate because they're tiny. We found fractured femurs, fractured ribs, fractured humerus. Kid was 3 months old. Now, what is my job as a nurse? Well, of course, I reported it to the charge nurse. We got, the people in there to help, DCF, police, everybody, because your job is to make sure that kid is safe, right? That is your job. I wanted to scream and yell. I mean, it was the mother who brought the child in, but it wasn't her who had done it. So we did get that kid safe, and the person who had done it was put in jail. So the kid is now safe. Another thing we look at is, how clean is the kid? Now, the kid was out playing baseball and got hurt. They're not going to be clean. But is their hair greasy? You could tell many different things. Remember, clothing is not proper clothing, food or shelter, even schooling is neglect. So again, these are things we're looking for. Now, it doesn't mean you're going to find many in your career, but find 1 or 2 like I did, and that you did your job, that you saved a kid from future abuse. So the history. So tell me, what happened? The nurse is going to teach that child and those parents about injuries, and then, prevention. If the kid had took the vitamins and now has an overdose on vitamins. We're going to talk to the child if they're old enough, and we're going to talk to the parent about putting it in a safer place and talking about what could have happened. And even younger kids will understand you. So making sure that we're going to prevent that. You know, as we get these children in the physician's office or wherever we get to see them, we're going to talk about giving immunizations and washing their hands and, you know, illness prevention. There are many questions that parents will give you. What can I give my child for an itch? What can I give my child for a cough? Remember, many of these things, if you're there with a child and they have an itch, will tell the physician. And it could be just Benadryl over the counter, okay? But even cough medicine today on younger kids, we don't give it. We give something very, very benign. You know, even they have these infant drops that are non-medicine, like honey and lemon type things that we do use today. We have found that too much Benadryl on children daily could be dangerous, okay? Because then they're taking something that, you know, calms them down and puts them to sleep. We always want to know where their immunization history is too. Are they up to date? Are they doing what they're supposed to do? Because if they come in sick, you want to know that because they have no immunizations. They come in with a fever and a cough. You might get what they have. So then we're going to put our masks on and be safe. We always need to know how the kid is feeling on a daily basis. Are they full of energy? Are they running around? Are they drinking? Are they eating right? Are they picky eaters? We know children are picky eaters. So we need to, you know, make sure that they get enough of the proper food groups. Sleeping. Remember, when you put a child to sleep, you know, there needs to be a routine. There needs to be, this is what's going to happen. I'll come in. Here's a little sip of water before you go to bed, but no water at the bedside because you're going to pee the bed, especially younger children. Older kids, sure, leave the water there because they'll go up and urinate. We'll read a story, and then I'm going to give you a hug and a kiss, and then it's good night. And that's your habit. That's your routine that you do, and kids do better, especially younger kids with sleeping. Toileting. We know that bowels training is done before potty training for the urine. We know that when they hold their urine for 2 hours with a dry diaper for 2 hours, we know they're ready. That's one of the telltale signs. We want to know their activity. What sort of games are they playing? What toys do they play with? How are they communicating? Are you able to understand what they're saying? You know, some kids go like this when they're eating, and this means more. Sometimes they want, you know, milk. You know, there's all different things kids do. And as long as the parents understand it, that's good. But again, if they're going into a hospital setting, you need to know that, especially if mom can't be there all the time, right? So, physical survey. Again, it's head to toe, not all in that direction. Remember, it's going to be as the kid lets you do it. Older kids will let you do things first that the younger kids can't. Again, it's the age of the child. And you could tell when you're trying to warm up to that child if they're going to be okay with just the head to toe. Many of them aren't. Now, when you're doing vital signs and you're hearing things, think about what these numbers mean, okay? So you take a temperature and it's 101. We know a kid with a temperature is not going to be eating, drinking. They're going to be sitting in the corner and they're not going to feel good. I mean, how do you feel when you have a fever? You feel horrible, right? Well, the kid feels the same way. Why do we give acetaminophen, ibuprofen? So they'll feel better, so that they'll drink, that they'll eat, because that helps them get better, right? Also, we're going to make sure that we medicate them, or we're going to tell the RN so she can get an order for that antipyretic, that acetaminophen, or that ibuprofen. Weight can make a difference on some kids. Some kids are too skinny, some are too heavy. So watching that weight, especially if we're, doing visits in doctor's offices, the last weight, the kid has gained, 3 pounds in 2 months. Well, that's a little lot. So finding out what they're eating, right? Give me a 24-hour diary on what this child is eating, so you know what's happening, because the physician's going to want to know that too. Blood pressure, is it high? You will find hypertension in young kids today. Years ago, we didn't take blood pressures on children. And we found out there are young kids who have hypertension. And if you leave hypertension not treated, you're going to end up with renal failure. That's black and white. It happens. So let's prevent it when they're kids, right? Heart rate. Well, heart rate, is it within normal limits or is it too high? Now, excuse me, you should count a pulse on a younger child by the apical for 1 minute. And why do we do it for 1 minute? Well, their heart rate speeds up and slows down normally. So if we get 1 minute, we're getting a good average of what their real heart rate is, okay? If it's too high, what could elevate a heart rate? Well, I've already mentioned fever. That will definitely elevate your heart rate. Well, what about dehydration? You don't have enough fluid, your heart beats quicker to try to get fluid around, but it doesn't have fluid, so it beats faster. So it's beating good. What if they're in pain? That elevates heart rate too. So as you're getting a number that you know is higher than what a child should have, try to understand why. Now, infants are really easy to tell that dehydration with. Older children, you'll see other things, but let's start with the infant. An infant has fontanelles, right? Anterior, posterior. The anterior doesn't close to almost 1.5 years. If it is sunken in, you know they're dehydrated. Their eyes will sunk in also, and they'll cry, no tears. It's really, you look at a little infant crying and they have no tears. It's like, oh my goodness, this poor little thing has no tears and they're crying. So you know they need fluid. Of course, we'll tell the nurse, we'll tell the doctor, what do we need to do? Do we give it by mouth? Do we give it by IV? Depends on that child's status. Now, as the kid gets older, and even the younger kids, you'll see prolonged capillary refill, you'll see a decrease in urinary output. These are things that would lead and show you an elevated heart rate. Respiratory rate can get elevated due to fever, could be due to pain, and it could be to respiratory distress. So again, counting it for a minute, seeing what the rate is, and then figuring out, well, what? Well, listen, what is it? What does it sound like, okay? Is it, wheezing in there? Is there rales? Is there rhonchi? Is there a lot of nasal mucus? Can they breathe? So these are things we'll look at. As I said, hydration status has to do with the heart rate, dehydration. Again, are their mucous membranes dry? That capillary refill prolonged, over 4 seconds. You're dehydrated for sure. Heart sounds, I think the neatest heart sounds to listen to is a heart that has a murmur in it, like a ventricular septal defect or a hole between those 2 bottom chambers of the heart. And it goes instead of that's a normal heart rate. But when you're talking about those murmurs, it's and you could just see that blood just flying everywhere inside that heart. So those are easy to tell, but we will be listening to heart sounds as again, 1 minute to get a good heart rate. Vowel sounds. Remember, we must listen in every quadrant to make sure that we're listening, that they have vowel sounds in every quadrant. Also, are you going to ask the parent, when was the last stool? Did they stool today? Yesterday? How many times a day is normal for them? What are they eating in their diet? Is it proper diet to have stools? Or are they just macaroni and cheese and chicken nugget kids? because there's many of those today because it's easy to fix. They got those little cups, takes 3 minutes, put it in the microwave, chicken nuggets, you put them in the toaster, done, and it's easy. And I understand. You know, I've got a little grandson that lived with me for many years, so I understand that it's easy, but again, it can affect their bowels. Also, when you're looking at them, looking the integumentary system is a vital part. You know, looking at their skin. Do they have cuts? Do they have bruises? Do they have rashes? Do they have lesions? You know, looking at those things can really give you a good sign of if they're getting proper bathing, or are they allergic to something? It could be that maybe the child had a new food and now they're having rashes, which is considered an allergy. We'll take it away for a while and then try to put it back later to see if they can eat it. So pulses and respirations, most common, if the kid is 2, we can do a radial pulse. You can do a temporal pulse. You actually can feel a pulse in the head on the premature infants. In fact, sometimes you can see it pulsating there. You have mandibular, you have femoral, and you have carotid all over the place. But I like to have a good apical pulse, the first assessment I do, and then I could do radial pulse from there on, unless there's a cardiac problem. They're saying that the apical is advised for 5 years of age and younger. Radial pulse is 5 years of age and older. And when you're looking at respirations, is it panting? Is it deep? Is it regular? Is it easy? Is it difficult? All of those things. Is there dyspnea, right? Difficulty in breathing. Very important things to check out and to look at. Again, those heart rate, remember if it's due to a temperature, the respiratory rate goes up because with the temperature, heart rate goes up and it's speeding, you know, needing more oxygen. So you're going to see those heart rates to go up. So again, what are we going to do to treat this after the assessment? We're going to make sure they get an antipyretic. Let's get that fever down. And this infant's respirations first. Remember, if they're in mommy's arms, relaxed, you can count a respiration without even touching them. Then you could sort of sneak in and do that apical pulse for a minute. Now, blood pressure cuffs are all sizes. You have one that's the size of my finger on the infants, and this wraps around their leg. That's how tiny. Those are double zeros. Then it goes up to extra large for big women like me and adults, right? But you need to pick the proper size according to the child, okay? Really important. Many times on first visit, I'll bring 2 blood pressure cuffs with me. I will check one and see if it's 2/3 of the upper arm or another one. If it's too big or too small, you're gonna have blood pressure readings that are not correct, okay? That's why we need it 2/3 of the upper arm. Children in their heart rates and respiratory rates are higher as children. Their blood pressure is lower. A newborn infant, blood pressure, normal, 60/40. We know that adults, we're 120/80. So you can see it's a lot lower. And as they get older, it comes up. By 1 year old, they could be 90/60, 80/60. So it comes up as they get older and older and older. You can take blood pressures in many different ways. Now, brachial or the upper arm, most young children do not like it. It pinches and it hurts. So what I'll do it is on their calf, which is their popliteal. And you could sort of hold the arm, distract them. Maybe have a sticker, or maybe have a cartoon on TV, or maybe asking them where their nose is, their ears are, their eyes are. They're distracted. Maybe have them push the button and say, let's see what number you are. Do you got a good number today? What number do you want to see? All right, make it a game. And having it on the lower leg, it doesn't hurt like it does the arm. I can't stand my blood pressure taken. It pinches these fat folds on my upper arm and it hurts. So I can imagine these young children, same thing. If you can get a blood pressure without the child crying, especially infants, it is accurate then. Again, sometimes an infant, give them a pacifier. That's a self-soother. Put it on the lower leg, hold that leg, and maybe pat their chest a little bit. Have them on their side so that these children are now sucking and they're feeling this comfort of patting their back. You'll get a blood pressure. Now, why do we use antipyretics? Acetaminophen, ibuprofen. Why? Well, maybe you're going to say it so they don't have a seizure, right? Well, if you have a fever, chances of a seizure are minimal. It's when that fever goes from no fever to a fever in 20 minutes. That's when the brain says, whoa, it got hot here, and has a seizure, okay? So once you have a fever, just like how you feel, children feel horrible. Now, one of the internal mechanisms that goes on with a fever is that infection, when you're sick, it stimulates prostaglandins. And this is this hormone thing in your body. And it helps with pain and it helps with inflammation. If you have a fever, what happens is that these antipyretic will inhibit that. It'll stop that from happening. So we need to get that fever down as much as we can, all right? Now, what happens with a fever? You're going to see hands cold and feet cold. Ever have a kid with a fever, touch their hands, touch their feet. If it's got a fever 101, they're going to be cold and they're going to be shivering. Okay, please cover me, right? And that's the worst thing you could do. You need the fever to get out. And as long as we get that fever down, you're going to be okay. Once the fever's done, antipyretics were given, then prostaglandins will start reproducing, which will help with that inflammation and that pain that the body needs. So hyperthermia is a high fever, but it's not due to the fever. It could be they're outside in the hot, or maybe they're in the car and the air conditioner isn't on, and it's something called hyperthermia. So this is the one where we need to get them in a cool bath, not cold, cool, warm to cool, and get that body temperature down as much as possible, okay? So hyperthermia is different from a fever, okay? Hyperthermia is because you're in a heated area. Something's gone on. And if you let it go too high, too long, it could cause the brain to have some damage. So how do you measure a temperature? You know, years ago, they said only oral and axillary and rectal were good. Well, they've got really good temporal artery thermometers now and tympanic. Really, really good. Rectal temperatures usually are only for the infants to get an accurate temperature. But as they get older, an axillary is just fine. Or those little temporal or tympanic thermometers also can work really, really well. So making sure you get a good, accurate temperature. I always, if I get one and it doesn't look right, let's say I've done the right arm, I'm going to go to the left arm. Or if I have another way to take a temperature, I'm going to do it that way, just to correlate. Where is that fever now? When you go in and do your morning vital signs, your morning assessment, or in a doctor's office, you know, doing your little routine, you're going to ask their pain level. Remember, there's different sort of pain scales for different age children. Now, back in the early 2000s, one of the governing agencies, the Joint Commission, said that we weren't focusing on pain, especially in children. We just didn't think they had pain like adults do. Well, they do. If you have an earache, they hurt. So yes, they do have pain. So now every time we do a set of vital signs, at least, you know, twice a shift, you're going to say, so what is your pain level? You know, we know the older kids, 8 and up, It's numeric from 0 to 10. What's your pain level? 0 is no pain, 10 is the worst pain in the world. We know that younger children, infants, up to age 3 will use the FLAC scale. And the FLAC scale measures their physical, their faces, their legs, their activity, their crying and consolability. And that's FLAC. And it's a really good scale and it works good. And it's not only on the young children, nonverbal, especially like in cerebral palsy, we can use it. And then the preschooler and school age up to age 8, we use faces, which is those faces of smiling. And they do actually do really good by doing those pain scales. Remember, if you see pain, make sure you do something for it. And pain isn't always just giving medicine. It could be distraction. It could be positioning. It could be hot. It could be cold. It could be something else. So I would like to say pain medicine, give it, and do something else. It could be that their tummy hurts and they're laying flat. Lift their head up, or give them a pillow to put on their tummy. They can hold their tummy. Whatever it is, do that second thing, those non-pharmacological interventions. Now, weight is really, really important. You know, in pediatrics, we just don't give 2 Tylenol like we do that for the adult world. We just don't. So making sure that we have it in kilograms, and we're going to be doing milligrams per kilogram. Now, I did send you all a dosage calculation video, and I sent you 2 different worksheets. Anybody doesn't understand how to do milligram per kilogram doses, please let me know, and I will tell you and help you understand it extremely easy, okay? So we know that if we're doing anything for a child, it's milligrams per kilograms, and we need to make sure that it's safe. How do we do infants? Well, I like to take and put them on that stretcher with that paper, mark the top of the head, pull it down, hit their feet, and now I've got a good place and measure it. How much in centimeters or how much in inches is this child in length? And then older kids, you can put them in a standing position. Now, there are these things that do the height, but this little board comes down on their head and they get scared. They think that thing's going to come down and whack them in their head, even that little metal thing that comes down. So make sure that we teach them that it's not going to hurt. Show where you're, do a height on yourself once. You say, look, my number's a 7. What's your number going to be? Again, make a game of it. And they'll step up and be tall and get a great accurate height because it's important. Now, head circumference is important. Well, we know children are born with a huge head, right? And we know that their chest circumferences are smaller at birth. So their heads are big, their chests are small at birth. By about 1.5 years, they should be equal, or the chest should be more than the head. Now, what are things that could cause this head to be continuing to be too big? Well, what if you have hydrocephalus, which is water on the brain? What if you have a brain tumor? What if your fontanelles aren't closing the way they should? There's all different reasons why. So this is why we do these head circumferences, to make sure the child is progressing normally. And if not, we're going to figure out what's going on. And we do it right above the eyebrows all the way around. And we just very loosely will pull it together and we'll get a number. How do you collect a specimen? Well, number one, before you do anything, you always check a doctor's order. Maybe that nurse before you told you you needed to do something, but the nurse before her had already done it. So make sure you check the order and make sure it wasn't done already. I think it will eliminate a lot of work for you. Make sure you have the proper paperwork, the proper, ID slips, stickers on it to show, who that patient is. Make sure you pick the proper equipment. If you are going to do a urine cath, make sure you have all that equipment, and if you need anything extra, fine. If you need help, get help, and then collect that specimen. Make sure those names are placed on blood or on urine or on cerebral spinal fluid, whatever it is of a specimen. I can't tell you how many times on a small infant sending blood or urine to the lab that didn't have a name on it. They're not going to accept it. So guess what? You have to do it again. And you have to torture that child again, according to the parents, right? These parents are like, what's wrong with you? Then now there's going to be problems. So make sure that you put the names on there. Always record your intake and output. Always report what specimen that you took. And, we do sometimes with some children mark a wet diaper. Infants, we always weigh them. How do you do a output on an infant's diaper? Well, a dry diaper weighs a certain amount. For instance, a number 1 diaper weighs 30 grams. You take a diaper off a child, an infant, it's wet. You weigh that diaper. Let's say it weighs 60 grams. Well, the difference between 60 and 30 is 30 mLs in urine output. And that's how you do an output on an infant with a diaper. It works well, and it's extremely accurate. So type of specimens that you might get, urine, it could be older kids and clean catches, or it could be a calf specimen, could be a bag specimen on young children. They don't really like bag specimens because it's, especially if you want a culture, because there's a lot of body, bacteria that could contaminate. And we want a good urine specimen, especially on the young children, especially if there's a urinary tract infection. We want to treat it one time. We don't want to treat the contaminant. We want to treat what the real urine infection was. Stool, you might need a piece of stool. You might need just a swab of stool. So it might be swab on a little card. So knowing what you need to do for the specimen. Blood, did you put it in the right tubes? Again, are you labeling these things, please? Cerebral spinal fluid, you're there assisting the physician doing a spinal tap, making sure, again, that they're labeled and that they're carried to the lab. Very important. Sometimes we have these wounds, that aren't healing, and we'll do cultures on them. And sometimes it's just a culture little swab that they do. Sometimes they'll swab it and put it on little slides. Whatever it is, make sure it's labeled and it goes to the lab. And you put it in one of those biohazard type of bags. Now, sometimes we have things after, let's say you had a ruptured appendix. A lot of times they're going to put like a drain there to help drain any extra fluid. Sometimes we're going to take that little thing, it's a Jackson Pratt, which is a little bulb thing that you squeeze and put the lid on, and just a little suction to get extra liquid out of the peritoneum. You could take it and put some in a little sterile cup and send it. And because we want to see what's going on with the peritoneal fluid. Is it with infection or is it getting better? Always follow hospital protocols, how to handle it, how to, hold on a second. I'm teaching. Sure, goodbye. Aren't husbands needy? Excuse me, I apologize. All right. So when you're doing anything with protocol, make sure it's in the bag, make sure it's labeled, make sure that it doesn't go through a tube system if it's not supposed to, that it's carried there. If you do things the right way the first time, you'll never have to repeat anything, okay? When you take, and sometimes you can collect urine from a diaper. I love it. Now that's grandma, his mother. All right. Another thing is sometimes you have a diaper and you can pull urine off the diaper. We use that for maybe a glucose or looking for ketones on a little strip. We can do that. We pull the little wet piece of the diaper, put it inside a syringe, and we can get a little by pushing down the plunger, get urine. We can't do that for a urine specimen because there's still little pieces of the diaper in there, so you can't do that. So when we give medications to infants, whether infants or elderly, they're just so close in what can happen. Remember, there is what we call drug absorption, distribution, metabolism, and excretion. So that's how was that medication absorbed into the body? How did it get to where it needed to go? How is the liver? Is the liver working good? And remember, liver and kidneys in younger children are still immature. So it's really important to monitor these medications we're giving. And many of them, you're going to do drug levels to make sure that you're not giving too much. Some children, due to illnesses, due to liver problems, kidney problems, need smaller doses. So always keep that in mind. You're like, well, this doesn't seem like a lot of medication. Well, why isn't it? Oh, that's right. This kid has a liver problem, or this kid, they're working him up for kidney issues. So that would be your answer there. So we know age is an absolute determinant. And how are we going to give any medications? Again, we know infants, the way we give medications, their intestines are immature. They can't even eat food. So it goes out quick. So maybe we need more medicine than less, okay? Topical medicines are absorbed. I had one child who came into me. He was like about, I think, 8 years old, 7, 8, and he had a rash on him. So the father took topical Benadryl and rubbed it all over his body. Then he gave him a dose of oral Benadryl. He came into the ER catatonic like this, and he wasn't moving. And I'm like, oh, this is a Benadryl overdose for sure, which in time, it released and he was okay. But remember, even steroids you put on your body, they are absorbed. So let parents know, littler is better, more is not. And we know anything given with a needle, parenteral, it's going to get there quicker, right? If it's IV, it's gone, it's in there, and it's quick acting. IM, it's going to take a little time to get there, but remember, we got to put that IM injection in an area that's nice and healthy, because it will get into the system a lot better. As I said, metabolism is metabolized in the liver. We don't give many medications that are not metabolized in the liver with children. So children, again, it's slower. Remember, it also depends, did they have food before they took the medicine too? That makes a difference. So, and then even if they didn't, it takes slower time in order for them to metabolize the medicine and get it to the body. And you can see that liver and the enzymes don't function at a mature level to 2 to 4 years old. So younger children, it takes longer for it to get in the system. Now we know many medications are excreted by the kidneys. Again, their kidneys, like I said, are immature. And it does affect how the medication is excreted. So between, that stomach takes a long time to empty, to get the medicine down, and then the food gets the intestines and it just rushes right out because it's immature. You're going to see food in the stool. You might even see the medicine in the stool. Also, the liver, it's still immature. It doesn't work all that well. So, and sometimes the kidneys are not working well and it's not getting rid of those medicines. So this puts a child at risk for being toxic or a risk for toxicity. And, toxicity, many medications can cause hearing damage and could cause kidney damage and all sorts of things. So we don't want to do that. So remember, medications in children is serious. Even giving acetaminophen, remember, it is liver toxic or hepatotoxic. So always, always observe for these things. If you see that the urine output has decreased, or you're seeing the child getting lethargic, or you're seeing maybe little yellowish tints, anything, let your nurse, the doctor know something's going on. But also, besides just negative, say, okay, I gave the child some acetaminophen, the fever's down, the kid's eating and drinking. So there's positive and negative responses. Always look. Remember always to do all the rights before you give any medicine. And of course, always check that ID, right? So that we make sure that they're getting the proper amount. And I always myself will look at the order. In pediatrics, they have to tell you how many milligrams per kilogram per dose per day of whatever like antibiotic this child will get. So making sure that we are giving the proper dose. Now, parent teaching. It's essential to make sure that children get what they need on the schedule they need. Many times I will have them, especially with a kid with a fever that has an antibiotic too. I will, especially if there's more than one adult in the house, I'll tell them to have a piece of paper. And that whenever you give whatever, write it down in the time so that if somebody comes behind, they're like, okay, I gave it this time. All right, it's due. I can give some more acetaminophen. Or, oh, look, the antibiotic's due. Let me give the antibiotic. And it really will help in errors also. If this kid's been sick for 6-7 days, you're not going to remember what time you did what. So writing it down is going to help. So making sure that we write it down and follow the schedule, it will get the kid healthier quicker. Now, getting a kid to take meds. All kids don't like medications. So sometimes we need to encourage them to take their meds. Sometimes before we pick up, let's say that antibiotic or those Tylenol or Motrin, we'll ask them what colors do they want, to try to get that orange ibuprofen or that red or that purple acetaminophen will help with compliance. So make them involved in the choices. And we know we can give flavors in our antibiotics now. Have the child pick the flavor. Maybe that will help with compliance. We can give oral medicine. That's what we do at home. Remember, we don't squirt a syringe in the back of the throat because they'll gag, choke, and they'll puke on you. Should be on the side of the mouth. That does help. There are, as they get older, like pills that they can chew, ibuprofens and acetaminophen. They can chew them. Make sure they chew it and then wash it down with a little bit of water. We know IV, follow the hospital policy. Some need to be given slowly. Some can be given quicker. Now, as a LPN, parenteral would be those antibiotics that you can hang up on the pump. Make sure you know how long you have to set the pump for, okay? Nose drops, ear drops, eye drops, how do you give? Pull down and back the ears, putting it in, have them sitting up, putting a cotton ball in them, or leaning forward, blowing their nose, and then getting the nose drops in, and then eye drops, making sure that it goes in where it needs to. Ointment, make sure you pull down the eye, get it in. And if you're giving ointment to a kid, make sure you tell them their vision's going to get foggy. That ointment causes it. And we usually don't use that till the nighttime. Sub-Q and IM injections, make sure you're putting it in the right spot. Older kids can get a deltoid IM. Younger kids, the infants, will get the vastus lataris for sure. And subcutaneous could be arms, could be belly, could be leg. It's wherever you feel you can be more comfortable. Giving these injections, if you have a parent, you can use a procedure that I developed for the hospital system down here. And it's called Huggies. And it's H period, U period. It's the acronym, not just the name. And it's actually copyrighted. It's mine. Help us give great injections efficiently and safely. As in, have the parent hold their child for the injection, because now they're where they're more comfortable. It's less stress, less fear, less pain, as seen by less crying on those children that were held by those parents. Doesn't mean I'm not going to have another nurse to help me hold a leg on those smaller kids, because you will, because they will flinch, but it's going to be less traumatizing for them. So giving medicines IV, we know we have saline locks. We still can hook up pumps and give them medications over the time. Make sure you flush them before, check them for patency, look for any redness or swelling, and then of course flush it when we're done. There's central lines. We have all different names of things. In children, we use a lot of Broviac or implanted ports or PICC lines. PICC lines on those long-term cares, we do them a lot. And then ports for those children like cancer children, where we give it to them. Remember, IV push is the RN, but you can hang up medications on an IV pump and give it that way. So these are the different volumes for IM administration. I feel like I'm back in pharmacology, teaching you the amount. Now, remember, it also depends on the size of the child that you're working with, but these are your guidelines. You shouldn't give more than half an ml for an infant, because it's just going to be too much medicine and it's going to hurt and burn, and it could cause more complications. Toddlers are bigger. They got bigger muscles, more fat. You can give an ml. School age, adolescents, as I said, put it in the arm up to 1 ml. And then the vastus lataris, sometimes you have to have a big dose of Rocephin, ceftriaxone. That's one of the biggest things we give for a lot of infections. We give it with lidocaine, so it's numbing, so they don't feel it, okay? Mix it with it, which is actually really helpful. And we can give it vastus lataris up to 2 ml on these children, especially those nice pudgy legs. Remember IV, when we're giving it, that it goes directly in the bloodstream and it works really quickly. It's absorbed quickly, and it's the fastest route of administration. Remember, as we're giving any IVs, you're going to check the IV. Is there redness? Is it leaking? Do you see any fluid? Is there swelling? First thing you do when you see redness, swelling, leaking, turn the IV off, okay? If you need somebody else to check it with you, go ahead, try to flush it. You can't, the IV is not good, and then we can get set up for another IV. It can cause an inflammation of the vein, or what we call phlebitis. And that's that redness that you see. So parenteral fluids, every hour you should be checking that IV. You should be checking the IV flow rate on the pump. Kids love to play with it, and so do parents and teenage kids that come in, their brothers and sisters. I've seen it change. So make sure that you do check it. We also, in the smaller kids, put a little burette, which is this little tube that we put the IV fluid in it and put like only 2 hours of fluid in there. So even if it opens up and dumps in, we know that we're not going to overload these children with 500 mLs of fluid, right? Because that could happen. And then they're in congestive heart failure. So checking the rate of flow, not putting too much fluid in those on the tiny kids. And again, looking for pain, redness, swellness, or any moisture at all. And any child with IV fluid needs to be on intake and output. That's oral, that is anything, even the smaller kids, whatever you flush the IVs with, are also counted as intake. So depending on the hospital policy and what they want. So nursing care. So you need to know the child, their developmental level. Are they going to, do they suck their right thumb? Does that comfort? I'm not going to put an IV in that right hand, right? Because they're going to be bothering that IV all the time. Even with an arm board and taped up, they're going to want to mess with it. So put it in the other hand or somewhere else, right? So placement, so important. Now, preparing the child for an IV insertion. Now, infants, put mom holding the hand with a pacifier to talk nicely to your baby. I'll hold a hand, or I'll put the IV in it and tape it, board it, so that the child, and make sure there's nothing sticking out. They can stick their fingers in and pull their IVs out. And they do well. They actually do very, very well. They actually don't like their arm held, but with that distraction of the mother and a pacifier, they do good. Older kids, today we are great in pediatrics. We will put some numbing stuff on the area. And one of the things that the hospital down here used was something called a J-tip, where it looked like a little tiny syringe, but there's like an engine on the end where you push it and it pushes air and poof, it sounds like a soda can opening, all right, when you pop the top. And it pushes the numbing stuff into the absolute area, like a little small circle of where you're going to put the needle. So they're going to feel touch, but they're not going to feel pain. So I make little games up, like, I bet you're going to jump when I do this. And they jump. And I said, see, I told you. Now remember, I'm going to hold your hand. You're not going to move. You're not going to feel pain, but you're going to feel me touching. Okay. And I'm just going to leave that little tube in your arm. I want you to know these kids do well when they're taught. And today in pediatrics, we do have child life people that can help you with the preparation. Again, make sure that IV is protected, that you have it taped up properly, but not overly taped, because you need to see that IV to look for infiltration, redness, swelling, and leaking, okay? And again, you want it so that they still can function normally. Again, don't put that right thumb in the mouth, don't put that IV there. And again, remember all those safety things we talked about with giving IV fluids. The 6 rights of medication, we need to do all of them: right patient, right drug, dose, time, route, and documentation. If you don't have all of that, you don't give it. And you go back and make sure that the nurse gets you an order for you, okay? And you will be doing documentation after each medication, okay? Make sure they take it, document. Make sure they take it, document. That will save you errors. And we also have ways that we do the BSA for, they say it's the most accurate for pediatric doses, but most medications in a hospital setting are milligrams or micrograms per kilogram, okay? And today, most hospitals will weigh children on admission with their kilograms. So you really don't even have to convert, but we know if a child weighs 44 pounds, and you want to put kilograms, you divide it by 2.2, so the kid will weigh 20 kilograms, okay? So you can, it's 2.2 divided, because kilograms is a smaller number than pounds all the time. Dimensional analysis, I don't do a dimensional analysis because I think there's a lot of different steps. I've given you some great handouts for it. So if you want to know something different to help, if you're not understanding it, let me know. And I would love to get with you or a couple of you and talk to you before the exam next week. Not a problem. So remember again, where's the IV? Preparing the child, having the family involved always helps. Also protecting that IV, and if they're up and mobile, make sure that it's secured properly. So when we are looking at drugs, you have to be careful of some interactions. For instance, One of the things that comes to mind, because it's a really regularly used medication, is Rocephin or ceftriaxone, which is a really broad spectrum antibiotic given intravenously or intramuscularly. Now, you can hang intravenous medications like this medication, but it cannot be hung with Ringer's lactate IV fluid. So that would be one of those things that you'd worry about. There are some drugs that are given, mostly more in the ICUs, that can't come in contact with the sunlight. One of them is called nitroglycerin, which is given for heart attacks in old people. But there are a couple in the pediatric world too. We don't use many of them, but they are there. If we're giving medications, make sure that we know that there are reactions. Iron supplement cannot be given with bran. Bran will decrease the effectiveness of iron. And if you're getting iron, you're probably iron deficient anemia. So no raisin bran for breakfast for that child, right? And if they're given something for seizures and they have a stomach problem, you can't give them together. 2 hours before or 2 hours after, you can give the antacid. Gavage feeding. You know, many times children, for whatever reason, now premature children can't suck, swallow, and breathe, but they can take, you know, their formula or they can take their breast milk in a feeding tube. So remember, if we cannot feed a child normally, give them a pacifier so they can suck and be calm, all right? And remember that go slowly. It's like, you think like 10 mLs is not a big thing, but on a little 1 pound baby, 10 mLs is a lot. Let it drip in slowly, okay? And what we're doing is we're giving nutrition to these children, and nutrition is so important. Many children, due to many issues, need to have a tube in their stomach called a gastrostomy tube. Some of them have a big long tube sticking out. Some you need to put a connector on. But again, you're going directly into that stomach. So make sure that if you're seeing drainage that's not what you normally see, if it's like brown or green, it's probably not in the right place, okay? Many of the times they'll look for, is there any stuff left over? And if we see a residual stuff left over and it's a lot, you know, we give it back to that child because it has all those stomach acids in it. But we would let the nurse know and the physician know. I mean, I had my whole feed left in there from last time. So you don't overfeed the kid. Enemas we do give. You know, the one thing that a child can do is control their bowels. Did you know that? I've seen children go 7 to 10 days without a bowel movement. And you're saying, why? Well, sometimes something's going on at home, there's stress, or sometimes they want attention. And they know mommy will come with me alone to the doctor if this happens. So my grandson actually, his stool, because he was potty training, blocked his urethra. He wasn't urinating. So we brought him to the ER. We gave him an enema, which took the stool out. It was only 2 days of stool, but it was a lot that came out. And then he could urinate. So enemas are given for all different reasons. I have seen kids, their whole intestines, you could see white coloring in the x-ray, which is all stool that you could see. So we give an enema. Remember, there's pediatric size, you know, that we do give. Pediatric Fleets enemas. And then there's tiny little neonatal ones. So we do give them, but we try not to give them as much as we can. We try to encourage the child to eat, right? Plenty of roughage, or we'll add something like a Miralax or something to help them go. Respirations. Now, infants are obligatory nose breathers, right? They breathe through their nose. So sucking, swallowing, and breathing is actually hard if their noses are all clogged, which means they're not going to eat well. So if you're hearing this mucus, or you're seeing it, or they're coughing, or you hear, you know, gurgling going on, you know, you would suction this infant. They're in the hospital, you've got suction catheters or bulb suction, you know, choose whichever one you feel is the best. But remember, too much suctioning can create more mucus. You clear that nose out and the child can suck and swallow and breathe. If they're older, many times they can blow their nose. That little bulb thing is what they need. In fact, I have them help me. Come here, get that booger out of there. And they will. They'll help you do it. There are different things that can happen, conditions children are born with. The tracheoesophageal fistula. This is a connection between the trachea and the esophagus. So if they eat, it goes directly across that tube into the lungs. So these kids can't eat. If there's a narrowing and it can't get down, again, it's going to come up, go in the lungs. If there is a problem with the trachea, infection, atelectasis, or any sort of problem, we know that if it can't go down, it's going to go somewhere. It will go into the lungs. Now, what do we look at with respirations? Well, initially, what you're going to see when a child is in respiratory distress or going into shock, you're going to see tachycardia. Late signs is bradycardia, and that child's about to code. So if it is a tachycardia, they're restless because they're hypoxic. Whenever you see restlessness in any patient, this is a sign of hypoxia. You're going to see the heart rate up. You're going to see them dyspneic. You're going to see those intercostal and the supraclavicular retractions, and they're going to look pale. And you know, and they're going to be laying there, just trying to breathe. When you see that, we need help. So get somebody in there to help you. So sometimes when you see an airway obstruction, so let's say they've choked up this mucus and it's clogged there, you know, that abdominal thrust, just like CPR's taught you. This could be when you choke on a hot dog, let's say. You can do these abdominal thrusts or on their back, back thrusts. So it can work. It pushes the diaphragm up, changes some pressure, and it will help them get rid of that mucus, the hot dog or whatever. Now, children do need to go to surgery for many reasons. You think of tonsils, adenoids, their ears, appendix, right? Those are a couple of the most common of things that I see. The older children make sure they know what's going on. Now, the difference between your adult world and your children world is the amount of time they're let to be NPO, nothing to eat or drink. Now, an infant should never be left NPO more than 4 hours. Many times they'll feed them up to 2 hours prior to going to surgery. And breast milk would be one of the ones be 2 hours before, okay? Remember, they're going to be frustrated, the infant. So again, give them that pacifier because again, that will self-soothe. Older children, let them know what's going on. And we know that children are scared. They're afraid they've done something wrong. Why is this happening? I'm going to bleed. I'm going to die. So telling them that they're not going to die, that they're not going to bleed, make sure the doctor makes sure the bleeding's all stopped, etc. I'm telling you, it does really help. Post-operatively, these kids, now all of a sudden they hurt. Like they don't understand why their throat hurts, why they can't drink. So again, say we can have some icy stuff. Which one would you like? Would you like an ice pop or you like some cold juice? What would you like? Or how about an ice chip? So helping them work through it. Also, making sure they have something for pain. A simple acetaminophen works well on children, the earlier children, because they haven't had many medications. So it actually works with that physical discomfort. So how was your lecture today? A lot, huh? Did you learn anything? All right, who wants to win the cahoots? Anybody? Oh, there we go. Tamika's gonna win. And William, watch out. William's going for it. 515-5638. Week 3 goes by so quick. What is the best pulse location for the nurse to use when assessing the pulse rate on a 12-month-old infant? And we know it's apical. On an infant, you do the apical. The radial is not good enough yet. And again, it's 1 minute apical pulse for an infant. What is the definition of a latchkey child? Those who went to my review have already heard about a latchkey child. I know I came home and I didn't have anybody at my house for about an hour and a half. I had older brothers, but that didn't mean anything. It's a child who's home alone after school without adult supervision. Remember, this latchkey kid, you have to worry about them. You know, they can get into accidents and they can get into situations that they shouldn't have. So preparing that child properly or having a phone number to call in case of trouble. A 9-year-old needs a lumbar puncture. What position will the nurse explain the child will assume for this procedure? I mean, I've gone into children that the doctor couldn't get a proper positioning on children. And I said, listen, I'm going to give you the biggest hug. And I'm going to hug him till he's done. You're going to feel him touching your back. They're on their side with their knees to their chest. And it sort of arches that back open, sort of opens up the bones, the spinal canal, opens it up, and they're able to get in the needle. And of course, you don't want them moving. Positioning is key. An infant's dry diaper weighs 2.5 grams. The wet dry diaper weighs 47 grams. How would the nurse record the infant's urine output? Remember, it's the difference between the dry and the wet is the urine output. And even if it's mixed with stool, we call it output, okay? We don't delineate the both in infants. A multi-select. What medication should be checked with a second licensed nurse prior to administration? These are what we call high alert, right? Which of these are high alert? And the reason why we do that is to prevent errors, because there are higher levels of risk for overdose for these. The only thing is the antibiotic. Yes, vancomycin it's very, nephro and ototoxic, but it's that heart medication, digoxin. It slows down the heart rate. It's insulin. It decreases blood sugar, morphine, respiratory depression, and heparin blood thinners. All of those, you need a second witness, and they must come in and sign on your chart. It's very serious. Multi-select. A 3-year-old patient is admitted to the pediatric unit with a fever of 103. Which actions will the nurse implement? So fevers of 103, they can get a little delirious. I mean, 103 is not really high. I've seen 105, almost 106, but still, some children at 103 will get a little delirious. Skin turgor, we want to make sure they have enough fluid on them, right? And then we want to give that whatever the antipyretic is, the acetaminophen, the ibuprofen, whatever ordered, we need to give it, because we want the fever to come down so the child feels better, right? It's not for seizures because he has a temperature already. It's for that comfort level so that we can get them drinking and eating, feeling better. What strategy might the nurse use when administering oral medications to a young child who is reluctant? You never tell them it's candy. You never mix it in food or drink because you don't know if they took it off. They don't drink all of that stuff or eat it. Give them a reward when they're done. Here's a fruit juice. Here's a popsicle when you're done. Give them a reward. And then again, you could also, do you want to chew a pill, drink a liquid from a cup? Do you want it in a syringe? Do you want it in a spoon? That's what you can ask them, but you would never mix it into anything. So good. I'm glad you didn't choose it. Order ampicillin oral 400 milligrams PO every day. And the vial reads ampicillin 125 milligrams in 5 mLs. How much per dose? Now I know this is quick to do it. Just we're going to discuss how we're going to set that up for an answer. What do you want to give? Over what the pharmacy gave you times the quantity it comes in. 5, right? So it's 400 over 125 times 5 over 1. Multiply the top, divide by the bottom, and it comes up to 16 mLs. If anybody didn't understand what I just said, please look at that recording I gave you or ask me. I'll help you. Here's another one. 150,000 units IMBID, and the vial is 600,000 in a 5 ml. How are you going to set it up? You can all have calculators. You can all do the math well. You have to set it up properly. That's number one. So it's 100.
I lost connection.
That's okay. 150,000 units over 600,000 units times 5 mLs, and it comes out to be 1.25 mLs. As long as you set it up right, you're going to get the right answer. Lovenox, 50 milligrams every 12 hours. The vial is 105 mLs. How many mLs per dose? Again, desire. What do I want to give? 50 mLs. What did the pharmacy send me? 100 mLs. And it's in how much? 5 mLs times 5 over 1. So 50 times 5, 250 over 100 is 2.5 mLs. Is everybody following this? Okay, as long as you're following it. A parent says, I'm not sure how to give this medication to my infant. What's the best response from the nurse? So you take an oral syringe and the side of the mouth and slowly give it. And actually, the infant will take that syringe and sort of suck on it slowly. Just don't shove it in there because they'll gag and they will puke, and you don't want that. A 6-year-old takes iron supplement. The nurse advises that which food decreases the absorption of iron. I would tell you vitamin C enhances absorption of iron. So I would say give it with orange juice. Most kids like orange juice, but what will decrease it? And it's bran. I mentioned it earlier. No Raisin Bran for this kid, right? If he's taking his iron. The incoming night nurse gets a report on his patients from the day nurse, which finding requires immediate attention. So when you see this widening pulse pressure, something is going on with that child. There's something that's happening, could be going into shock, and it's something that's immediate. Now, an adolescent with a respiratory rate of 28, they can tolerate that. It's not as immediate. The widening pulse pressure is more of an emergency. An infant heart rate of 100 at sleep could be perfectly normal, and that's the normal temperature for axillary, would do nothing. A 15-year-old returns to the unit following a lumbar puncture. What initial position should this patient be in? I mean, literally, they've gone into the spine and they've taken liquid out. It's like giving spinal anesthesia. You treat them the same way. So they should be on their back flat. If you lift them up too quick, they're going to get a headache. So if at all possible, if they have an IV, give them fluids or give them some fluids so they can wash out and return that fluid to the body, okay? Slowly raise the bed. Get them up quick, they're going to have a horrible, horrible headache. I'll multi-select. Informed consent for a minor guarantees that the parent or legal guardian understand which aspects of a procedure. So you're signing a consent for a tonsillectomy. So you know the risks, you know why. It will be signed and witnessed. Anybody can witness a signature. Okay, you have ER clerks that do it all the time, or clerks in the hospital, the admission clerks, and that they got information about the procedure. Now, no suit for damages. Well, there's risks for any procedure. So they already understood it. They gave them, they understood it. Doesn't mean that they can't sue. It has nothing to do with that. The nurse notices her 2-month-old patient does not have an ID bracelet. What should the nurse do? So you need to confirm who they are, and you need to tell the charge nurse. Now, sometimes the floor can make them, sometimes it must come from admissions. That's whatever procedure it is. But you tell the charge nurse and she will make sure that they get it. So know who that child is. And you can't do anything. You can't give medication till that bracelet is on them, okay? Gentamicin eardrops are prescribed for a 4-year-old. How would the nurse position the auricle? Remember it from pharmacology. and you pull it up and pull it back, and that opens up the ear hole, okay? And you'll be able to place the drops in there. Remember, it depends on the age of the children. 4-year-old, that's the way you do it. What is a tympanic thermometer considered more accurate than other types of thermometer? Why? It shares circulation with the hypothalamus. When they first came out with it, nurses had a hard time, saying, well, it's an ear, how can it be accurate? But after research and then telling us these informations, we're like, okay, now that makes sense. So they use them a lot today. Which intervention is correct when a nurse is administering a gastrostomy feeding by gravity? So you're just going to position them on the right side. And why? Because the stomach is on the left side, and it will allow it to sit there and not be squeezed, and it can, empty out into the intestines by then, and that's why. How often should a child who has continuous intravenous infusion be assessed? I mean, most nursing charts, especially those electronic, have it there hourly, and you have to check it that you've seen it every hour, because 10 mLs on an infant can be a big amount of fluid. So you don't want to damage the skin and create ulcers. I've seen big black hands from infiltrate, or feet. It does happen. So we check them every hour. Which intervention will the nurse implement when suctioning a tracheostomy? Now, that's the tube in the neck when they can't breathe out of their mouth for whatever reason. So the big thing is when you're in there suctioning, you should not have suction going for more than 15 seconds, which means they're not breathing. They're not getting oxygen during that time. 15 seconds is a long time to have a child without breathing, to get up that mucus, okay? What emergency action should be implemented for airway obstruction in the infant? You swallowed a hot dog and I can't breathe. When I was a young kid, I had a lollipop that I swallowed and I couldn't breathe. And this is before they had CPR. The next door guy from the hardware store came out and shook me by my feet like this, trying to get it out. They didn't know how to slap the back or anything. So it's back blows and chest thrusts that can get it out. But on the way to the ER, to the hospital, which is right up the hill, I actually swallowed that lollipop and I was able to breathe. Thank God. So I've had an airway obstruction. I remember it clearly. A 4-year-old says tearfully that IM injection will hurt. What is a nurse's most effective response? And today, remember, we do have numbing creams that we can use on these children for immunizations or IMs. And never lie to a kid. Tell them it's going to sting a little bit. Like the Rocephin I told you, we put it in lidocaine. That initial is going to hurt and then the pain goes away. But tell them, be honest. That's what they want to know. Don't lie. Where is the best site for giving an IM injection to a 15-month-old child? And that's the vastus lataris muscle. That's the leg, the upper outer thigh. Big, meaty things are good. Adolescents and older children, you give an IM in the arm as long as it isn't a burning type medication. And there are some of those too, but mostly in the arm you can give it. And last question. What factor does a nurse explain affects the infant's psychological response to medications? The physiologic response. What do we know about infants and the way they respond to medications? We know that they have immature kidney function. And we know it's going to go, if it's orally, right through the intestinal tract because it's not mature, right? That's why you even see food that will be in the intestinal tract before 6 months. And even after 6 months, you can still see food that hasn't been absorbed and used. All right, let's see how we did. Who won today? Number 3, Sam. Good job, Sam. Number 2, Ari, R. And number 1, Tiona. Good job, Tiona. Number 4, Mary and Son. So this is good. All right. Any questions by anybody about anything? Remember, next week is going to be your first exam. You're going to come in on your Zoom on your phones. Make sure it's charged, okay, or plugged in. And then you're going to take your exam on your laptops through ExamSoft. All right. I will be checking your IDs. Make sure you have your Fortis ID or a driver's license. It will be recorded. And when the exam is done, there is going to be class. Now, you've seen the message I sent out for those who wanted to take it on campus. Because you're not on Zoom with me during the class, you don't get attendance for not being here, even if you had that exam somewhere else. And this is according to the dean, and all the deans got together and agreed that this is the way it would be done. I understand some of you are upset with it, but that's the way it is, and I apologize. If you do take your exam somewhere else, I need to know from who's ever proctoring you, or else they can't get into my exam. They don't have access. So I have to know who it is, and they have to send me who they are. Don't tell me this is who's going to proctor me. I need to have them email me, I am proctoring such and such and such and such for the exam. And it has to be on around class time on the same day. Okay? All right. Let's go to your modules. Go to exam 2. I mean, quiz 2, sorry. When you are done with your quiz, you are done for today's class. Again, anybody who needs any help with anything, let me know. If you're not understanding anything, you need a review with me, I will do that. If you need help with dosage calc, you let me know. So from now on, if you have any questions, put it in the chat box. I'm going to go on silent and I'm going to let you do your quizzes. When you're done, you can go.